And before going to that, what's Stop Pregnancy with Dr. Nuela all about? This is an organization with aim to improve the health of women, children, and adolescents, especially those in remote communities and in areas highly affected by crisis. So we have seen that most of maybe some complications that occur during pregnancy, it could have been solved way before the woman gets pregnant. And there are a lot of things that women might suffer from. But if they are tackled way before she gets pregnant, then that is the best thing. So we are going into primary prevention. You should not get into the problems before you start thinking of how to handle it. And guess what? If you're getting into the problems, most of the times it's usually already severe, or you must have gone through some stressful or mental health issues or a lot of stress before you're even getting to the solution of all this. And today's episode is very important. I can see from our community, we have been having a lot of people talking about, oh, we are just talking about men. How about, about women? How about the men? What's happening with them? But actually, it's not like we left out the men. No. We have been having sessions on the importance of male in preconception care. Maybe sometimes the men might not have been pushing it that much, but that's why, of course, to have a baby, we need the male and the women and the female. That's the sperm and the egg. So we cannot neglect the sperm. We cannot neglect the men because they are the ones coming up as well to make the babies. So here at Talk Pregnancy with Dr. Nuela, especially on this branch, which is the Action on Preconception Care community, we are out to ensure that both the man and the woman prepare for pregnancy. Yes, there are times that you might think you want to get pregnant now. Okay, most of the times you just say, okay, let me just get pregnant now. But there are a lot of things you need to do. And the World Health Organization has recommended 3 months before pregnancy. And if you want to even start late, at least 1 month before pregnancies, because there are some complications that have to be managed before you get pregnant. You see people having a long time to take in. Why? Should you be stressed if you try to take in now and you don't take in within that first month? Is there a problem with you? Do you start talking about infertility? You might already start getting worried when majority of the time the people don't get pregnant within the first month that they try. So those are some things which are being discussed during the preconception care period. So it minimizes stress and therefore maximizes or optimizes the health of both the mother and maybe the unborn baby. And in that case, you are also optimizing the health of the man, because once he comes for his checkup, if there is any problem, if there is any complication as well, it's going to be managed as early as possible. So that's why we are bringing to you this session today on male infertility. This is something that it has been coming up. We have been having this community, and thanks to our community managers, they have been managing the community so well. And we have had a lot of people coming up. And now I think the traffic for the men is really increasing. We are grateful for the men who are coming up, but we still need more of the men to be involved. We still need more of the men to talk about it. We still need more of the men to come to accompany their wives. Gone are those days when we're thinking that once the woman's test is negative, we assume the man's own to be negative. No, it's not like that any longer. Now we are having the female, they check themselves and they see that everything is fine, and you just want to go and check at the level of the male, and we discover some things there, or some complications have occurring there. But here you see that they have been trying for a long period of time and they are not getting pregnant. So here we are bringing preconception care out, and maybe at the end of this session our community manager is going to be telling us where we can have because now we have services in some hospitals. I think we saw it in the group. We have services now in hospitals, 6 hospitals in the Northwest region, which are working to set up preconception care units. So it's almost their doctors have been trained, nurses have been trained, who they can practice preconception, where they can practice preconception care now in these health facilities. I think that is thanks to this community and the work we have been getting, and the and what can I say, testimonies we have been getting from this community. So I think we can clap for ourselves for that. And many more successes are going to be coming up. And we believe that it is for the betterment of health in our society, betterment of good health for the family, because once the family is healthy, we assume that the community as well will be healthy, and you are able to carry out your daily activities, plan your life properly, and enjoy life in general. So I think without talking much, over to you, Rukaya. So you can host. I don't know if Dr. Ebogo has already joined, so that we can start introducing him. If he's there, maybe he could unmute his mic and let us know if he's present with us now, so that we can get into it, or we know what next to do. Thank you. Over to you, Kaya.
Thank you very much for that very educative session. See, the webinar has started though. Don't wait for the for guest speaker before you start taking down your notes. The webinar started. She just spoke about top pregnancy, Dr. Nella, the mission, the vision, and what preconception care is. So all of us now know what preconception care is all about. We know why it's important. And if we are thinking about having a child in the next nearest future, means after this webinar, we are all doing preconception care. We are doing our personal preconception care. We are looking care facility to do preconception care. And preconception care is the because you need the sperm and you need a man and a woman to have the child. So preconception care is for both of you. Now, in the northwest region of Cameroon, we have 6 centers where you can go and meet a trained preconception care, an expert that has been trained in preconception care and preconception care counseling. Let me just read them out. If you're in the northwest region of Bamenda, it has come to you first. This is the pioneer batch. So if you're thinking of having a child, you have to do preconception care counseling. That's a non-negotiable. So now, if you're thinking of having a child, you can go to the regional hospital of Bamenda, and they'll direct you to a preconception care expert. You can go to Bingo Annex Gwen. You can go to Tuba District Hospital if you're towards Balmai 5. You can reach slowly at. You can go to Gwen District Hospital, and you can go to Bambili CMA. So these are the 6 centers where you can easily go and meet top pregnancy with Dr. Noella trained preconception care experts. We train them ourselves, so we're very sure of the quality of and the delivery that is our main speaker here. Thank you, thank you, thank you. Dr. Ebogo, please, are you on? Okay, now that our
Yes,
speaker
yes,
is here, we
I'm
can
on and I'm
start.
filling up.
I know people have just been waiting for. Please, if you is your hand, do you have a question or your hand is up by mistake?
You're asking me if my hand is up, then it should be by error. It should be in error. Sorry.
No, I'm not sure. I'm seeing Nadine and Luke. Please, if you have any questions, you could just keep them. And after the session, you'll be given an opportunity to ask your question. So, Luke and Nadine, I think your hands are up. I don't know. Okay, Mukaya I don't know, maybe network issues. So she has to introduce.
About male infertility and
Okay.
everything surrounding it. So let's make welcome. See a very big welcome for our guest speaker, Dr. Ebogo. Please let's welcome him as he comes on board to talk to us. Thank you, thank you, thank you, thank you. Over to you, Dr. Ebogo.
Hello. I will like to know if you can actually hear me.
We can hear you, Doctor.
Okay, all right. Um, my name is Dr. Ebogo. I was just spent some time looking at the the participants in this webinar, and I see a lot of them are people that I know. Um, and so for those people that I know, I think I need very little introduction. But for those who don't know, my name is a biologist, and my area of subspecialty I'm also a amender, and in the University of Monrovia. My area of research, um, male um, um, genitoplasty, that is reconstruction of the male external genitalia, and also research interest in andrology and andrology and male and infertility in males. So I was very excited when Dr. Noella reached out to me, and we had a discussion on me participating in this webinar on understanding and overcoming male infertility. So this is I'm very honored to be among you, and I'm going to share my expertise with you. These are mostly the things that we see every day in our practice, and I thought of a lot of ways to do this presentation, and I thought of doing a formal PowerPoint presentation, and on a second thought, I thought it would just be like the same kind of things I do in the classroom. And out of that, I thought we could just make it a little bit interactive. So I'll share my insights on male infertility and understanding and overcoming it. And then we can have a discussion. I think it is easier when you ask your questions, and then we share our own experiences in this. So I don't intend to make it long. I intend to make it as short as possible and just go straight to the things that matters. So I've been asked to talk about male understanding and overcoming male infertility. And specifically, I've been asked to talk about uncovering the root that means talking about the causes of male infertility. And in this, we are going to look at the basics, that is the common and easily understood factors. We are going to look at just beyond the obvious, less discuss medical, genetic, and environmental causes, which are important things that you have to understand. Then we'll look at understanding the complexities, that is the multifactorial puzzle in male infertility. And the second part, we are going to decode the details, that means sperm health and diagnosis. Under this, we are going to look at what the test will reveal, or demystifying the semen analysis. We're going to dispel the myth, some commonly understood, misunderstood conceptions, and then the diagnostic journey. And in the last part, we are going to look at empowering choices. That means lifestyle and treatment path, the options that we have, modern solutions, and the medical and reproductive treatments. And then we are going to give space for some questions if there are, and answers as much as answers if we can provide them. I start by saying that the question of infertility is so broad, and we cannot have answers to all the questions. So now, for the first part of this, I will talk a little about uncovering the roots. Uncovering the roots, that means the causes of male infertility. So, under the understood factors. The first thing I will say in this webinar is this: fertility is not just a woman's issue. Male infertility contributes to nearly 50% of all cases of couple infertility. Yet, stigma and lack of awareness often keep men from seeking answers. Now, I want to say this. In my practice, I see a lot of men. In a week, I will have like 4 or 5 men who come and consult for infertility issues. And most of the time, these men come without their partners. So the paradigm is that they know they are the problem. They come seek for they come to seek for care, but when they go back home, they don't share this with their spouses, and they and the family keep putting pressure on the spouses and asking the wives questions which they can't answer. Sometimes the in-laws rain on the wife and say the woman cannot give you children, you have to get another wife and stuff. But the males know they are the problem. So the first thing I want you to know is we never discuss male infertility with the male. We discuss it with the couple. The disease is called infertility of the couple. So it's not a man does not get himself pregnant, or a woman does not get herself pregnant. So if there is infertility in a female, it is infertility of the couple. If there is infertility in the male, it is infertility of the couple. So they both have to come seek for care. So, like I said, male infertility contributes to about 50% of all cases of infertility. So, when we talk about infertility, what do we mean? Infertility means failure to conceive after 12 months of regular, unprotected intercourse. So if you have if we commonly we see patients who come to the hospital, they've been married for 6 months and there is no issue in their relationship. They come to the hospital, we tell them you do not meet the definition for infertility, so you have to go back home and keep trying. And until it is 12 months of regular means at least 3 times, at least three episodes of coitus, unprotected intercourse per week. So three unprotected intercourse in a week for 12 months. If there is no pregnancy, then we consider that couple as a risk for infertility. So I mentioned earlier that male factor infertility occurs in up to 50% of infertile couples. The most common causes of infertility include: one, sperm abnormality. By sperm abnormality, there are three major factors, three major things that we take into consideration before we talk about sperm abnormalities. One, low count. When the count is less than 15 million per meals, we talk about oligospermia. So low count means there is less than 15 million per meals. So somebody described it as um, less soldiers on the battlefield. So when there are less soldiers on the battlefield, that means less than 15 mils of sperm in the per meal of the semen. So it makes we consider that as sperm infertility. The second aspect of sperm infertility is poor motility. The sperm can't swim to the eggs. And thirdly, we talk about abnormal morphology. That means there is mishap in sperm struggle to fertilize the egg. The sperm may not be normally shaped. You may have heads without tail. You may have tail without a middle piece, or you may have abnormally shaped heads, or you may have heads without acrosome. And so we consider that sperm with abnormal morphology. So when you have sperm abnormality, I've said sperm abnormality contain three things. One of either low count, poor motility, or abnormal morphology. So these constitute sperm abnormalities and they are responsible for male infertility. The second aspect is varicocele. So varicocele is the most common abnormality of the testis that results in infertility. In fact, varicocele is present in 35 to 40% of infertile males. So varicocele means the veins that are supposed to drain blood from the testis, that means the veins that constitute the pampiniform plexus, are larger than they are supposed to be. So because of this, they can't drain blood away from the testes, and since they can't drain blood away from the testes, the blood settle around the testes, increase the temperature of the testes, and impair the development and maturation of the spermatozoans. For for sperm maturation to occur, the temperature of the testis must be 3 to 5 degrees Celsius lower than body temperature. So, but when a patient has varicoceles, the blood settles just around the testis, increase the temperature, and makes it unconducive for sperm maturation. The third factor is hormonal issues. Spermatogenesis makes a lot of use of hormones. So conditions like hypogonadism, that means low testosterone, will impair sperm production or sperm maturation. Other hormones like follicle stimulating hormone, luteinizing hormone, and also testosterone imbalances may arise due to disorders of the pituitary and or obesity or stress, and this disorder can actually derange the pituitary testicular axis and therefore lead to abnormal sperm production. Another factor which we have to take seriously is obesity. Obesity, endocrinologists will tell you that is associated with low testosterone level and high estrogen levels. So low testosterone level and high estrogen level will affect the DNA integrity of the sperm and therefore have an effect on the mortality and concentration of the sperm. So weight loss is a very important element in patients who want children. Now, another factor which is also very important are substance use. So examples of these substances include smoking, cigarettes. So smoking reduces sperm count by about 22%. This is very important to note. Just smoking, regular smoking reduces sperm count by about 22% and increases the oxidative damage to the spermatogonia, which are cells that produce spermatozoans. So smoking should be discouraged in males who are considering fertility. Also, the misuse of corticosteroids. The new shift in the world today is about the use of anabolic steroids for bodybuilding. Most young ladies this day they prefer men with good body build, and some men go to the extent of using anabolic steroids. So these steroids can cause a complete shutdown of sperm production. So it is something to also consider. And lastly, I want to talk about heat and pressure. So infertility has been shown it has been shown to be related to heat and pressure. In the we commonly see this in people who use a lot of laptop on on their laps and thighs. People who put on tight underwears. So these raise the scotal temperature, and when the scotal temperature is high, it hampers sperm development. In fact, I have a student who is currently working on male infertility, and one of the things that we see in the students' work so far is the high rate of infertility among motorbike riders. So we see, I think about a third of the patients or the participants in his studies have been motorbike riders. So we're looking broadly to see why do most motorbike riders have infertility in his cohort. Though this is not a published study, we are still working on the students' thesis. So we came to the consensus that as motorbike riders, they are sitting on the engine of their car, and this can actually lead um, to male infertility. So I want you I want to draw this analogy that sperm production is like baking bread. If the oven gets too hot, the dough or the sperm can't rise properly. So you can't get the temperature too high. Okay, haven't talked about the basics or the common and easily understood factors. Let's go beyond these obvious factors and let's discuss medical, genetic, and environmental factors. So some of the factors that are not under your own control or the control of your will include the genetic conditions. Three genetic conditions have been associated with infertility. You have the Klinefelter syndrome, you have the chromosome microdeletion, and the cystic fibrosis carrier. So I will just mention this in passing because these are not conditions that there's nothing that you can do about this. But it's just important to note them. So Klinefelter syndrome occurs when a patient has an extra X chromosome. X chromosome is mostly associated with the female genital or the female sex. So a male has the X and Y chromosome, while the female have the XX. So born with this genetic condition, Klinefelters, have an extra X chromosome. So they have an X and a YXX or an XYX chromosome. And this happens in one in 500 men, and it is often underdiagnosed. So they appear male, but they have a small testis which is firm, and then they don't produce any spermatozoa, so they are azoospermic. So patients with Klinefelters typically have a very small or minute penis. They call it micropenis. They have a hypotrophic scrotum. So the scrotum appears almost inexistent. And if the testes are there, the testes are usually firm and small. They generally do not produce spermatozoans. And this condition is difficult to correct. There are genetic tests, the genetic therapy today, or gene therapy today, like this, the Caspar-C and or gene knockout that are being used to correct Klinefelter, but these are all in the experimental phases. Then you have what they call the Y chromosome microdeletion. It is found in up to about 15% of men with non-obstructive azoospermia. So I've used the word azoospermia now twice. Azoospermia means there are no spermatozoans inside the semen. So when this kind of a person ejaculates, the ejaculate has no spermatozoan, or the semen has no spermatozoan. Spermatozoan can be of two types. It can be secretory. Secretory means that you fail to produce sperm as a whole, or it could be obstructive. sperm cannot pass out into the semen. So obstructive means that there is a blockage in the male tube. So I mentioned that Y chromosome microdeletion is found in men with non-obstructive or